Gerald, good morning to all of you, and it's really great to work in your cath lab. Yeah. Okay, this is about 45-year male. He had inferior myocardial infarction that was about 6 years back. That was 2015, 4 years back. Okay. And then he got stable, reasonably stable. He had angio in 2018, which revealed that he had LAD, LCS, and RC lesion 2. In 2018, his LAD and LCS was tackled, and he was left with RCA CTO. Now, this time he has come with angina again, so we are planning for CTO of RCA, which was present since 2015. It's about 4-year-old CTO, already intervened for LAD and LCX. Now we're going to do RCA CTO, which is about 4-year-old. Right. If you see angio now, my Dr. Werner will explain angio now. Do you want to explain angio?
Yeah. We don't have the previous angio, but the previous angio basically showed a collateralization of the right coronary, mainly from the circumflex, which now that is the previous angio. Okay, great. So you see this atrial connection that was feeding the PL branch, but you have a severe disease in the circ and the LAD. So these 2 lesions were treated, LAD diagonal with bifurcation stenting, and maybe we just show the final result.
Yeah.
Go back, back, back. Oh. We can also see the LV angio, maybe. This is the final result. Now the circumflex is closed, but there are other collaterals from the LAD still working. Maybe we have a LV here. There is akinesia, but it's not complete.
No, yeah.
So
yeah, looks more hypokinetic.
You can imagine, despite the EKG, that there is some recovery potential, even if we don't have an MRI.
But he had angina. He had angina now.
Ah, so he had an MRI.
Okay.
Okay. Yeah. So we expect LV function improvement. So today's angio. So the setup is radial 7 French with a slender sheath and femoral 7 French. I go radial always to the left system and femoral to the right system. It's a short amplatz 075 and an EBU 3.5 with a wire in the LAD. This is the first shot. The amplatz is a little bit deeply engaged. We see the collaterals. What frame? Yeah, you see the A plane. Okay.
Yeah, we're seeing the A plane. I think both the planes are set up probably, so you could choose whichever plane you. And he can.
Here
you can ask him if he can show both the planes together.
Yeah. Yes.
Yeah, we're seeing both the planes together now. Good.
So there is, well, maybe a tapered entry. The occlusion is certainly...
The RCA is a little deep, the catheter, isn't it?
Yeah, but that's corrected.
Okay.
So right now, I haven't done anything, so it's still open to discussion. You see the distal end of the occlusion is where there is a big AV branch, which was also feeding ipsilateral collaterals. But this is not a high bifurcation because we clearly see the PDA distal. It's a typical anatomy of the right. Okay. So strategies, quickly.
Do you think we should go antegrade first or retrograde directly?
I think I would think you should probably try antegrade first. You do have good septal collaterals, especially little from mid LAD. So, but still antegrade would be a better option. Somehow I am not very clear on the right because it's a deep injection.
So you're
or maybe
sure. Okay.
If I can see a better injection, what do you say, Dr. Pencheng? Can we have a better injection antegrade on the right? The catheter is too deep and
better injection. Okay. Does this make it any better?
Yeah, that's fine.
So we're planning to start antegrade.
I think we should start antegrade. And the retrograde filling was there to a reasonably long length.
Almost all.
So, you know, the occluded segment may not be that long.
No,
So
it is
it all
long till the
depends.
branch, RV branch. It
Can
seems to be
we-
reasonably longer.
can
If we see one left
increase the-
injection at this stage, one left injection,
No, we want to not use too much contrast.
okay, go ahead.
Yeah. So
Dr.
we
Penchang,
have
you have a point, you want to say something?
Yeah, Dr. Werner, and I am
Yes.
Dr. Peng Cheng from Guangdong Provincial People's Hospital, China. So will you, do you think there might be some kind of microchannel? I mean, even invisible microchannel, so that's why you start
No.
with filter ST family wire?
I don't think there are microchannels. This is an occlusion of 3-4 years. There are no microchannels in occlusions of 3-4 years.
There seems to be only
It's
homocoronary collateral actually.
What is completely always misinterpreted is residual channel, if you have a functional occlusion. But there are no microchannels. There is a study in the European Heart Journal of 80 specimens in 2013 that clearly states there are no microchannels in CTOs.
Okay, it's a residual
Then,
channel.
then what about that study which says 78% of CTOs have
This
micro?
was in 1995, yeah?
That's the old one, yeah.
When they had TIMI 1 flow considered a CTO. So one should really refer to this great paper from Rino Vermani's group, which is actually the gold standard on anatomy of CTOs. So I'm working with the XT, as we already discussed, and you see it makes now steady progress.
Yeah,
It's a
because
it's a
several
loose
times this
tissue.
XT crosses occlusions which you don't expect them to be crossed.
Yeah.
And I feel these are, I don't know, there are
But there is
certainly
no micro,
microchannel.
no, sorry. If you go to anatomical papers,
Okay.
ano-
So how does the
first-
XT cross then?
because it's soft tissue,
It's softer, okay.
and it's a very passive wire. So it took a little time to get started, but now it makes nice progress. I'm using a little bit the sliding technique.
Sometimes it's difficult to punch the distal part of the C2 actually, even
Yeah.
if you cross sufficient
But
length,
now it seems to
divert away.
divert away a little bit. So we
That
should,
track is okay? You think?
we should take a
left shot?
contralateral injection,
Yes, a left shot.
just the contralateral. Okay, go.
So
Stop.
Dr. Werner, is this a regular filter ST or STR or STA?
It's a regular old-fashioned XT.
XT.
So we don't see really, we are still far away from the
Yeah,
target,
yeah.
but the orientation in both planes is quite good. So I try to just progress, but clearly.
This is turning inside a bit
Yeah.
more.
So if it doesn't do what I want,
Because you cannot direct a XT. That is the only issue.
yeah, well, you see, I can direct. It goes a little bit in a different way now.
It's going to more interiorly now.
It's the better,
Yeah, it's a better choice.
yeah. You give it an option, and as it's a very soft wire, 0.8 gram, it will take the path of least resistance.
I think, Dr. Werner, you can work on it. We might like to, shifting to...
Give me
Just 2 minutes more.
Two.
yeah.
Yeah,
Okay.
let
No,
us see that
no, no.
how do we cross actually.
Yeah, well,
Are we
no.
able to cross integrity or not? Then you can shift to the lab.
Just 30 seconds.
No, don't hurry. Take your time. No
I know
problem.
we can also store, of course.
Yeah, because I have observed if you hurry on XTs, you...
No, we don't want to.
Yeah.
So let's give an antegrade shot. Maybe we have ipsilateral collaterals that are better. Okay. Go. Stop. No, we don't really see.
Can we see a left shot here? A good left shot
Yeah,
to
that
show
will
the
make it
distal
slightly
vessel.
better.
Let me
Yeah.
intubate a little bit more. Yeah, but it's all okay. Okay. Go.
Okay,
We don't need to film before you give contrast.
I'm gone already.
Well, still a way to go. Yeah, you can switch to the other
Okay.
hospital.
It is definitely
All
a
right.
longer lesion actually.
So can we switch to
Yes.
Trivandrum, please? Okay, Dr. Werner, we are back with you.
Yeah, you saw maybe some
Yeah, I
the
saw that.
actions we had. Okay, go back. Back.
So which wire is this? Did you change the wire?
So
Yeah.
we, back please. Yeah, okay. This is as far as we got with the XT, or at the level of the distal cap, but you can see, especially on the B plane, that it's making a shortcut. Yeah?
It's actually outside the branch. It seems to be in branch, it's actually not.
Yeah?
You see that?
But this, you see
your
it?
Distal wire end.
is
not
outside.
It's outside, is what we are saying.
Yeah?
It seems to be in branch, it's actually not in the branch.
But it defines the distal cap. So I leave the wire, I take out the fine cross with the trapping technique. Actually, I take a 2O balloon, because a 2O balloon is much easier to work with bigger devices. And you can use a 2O balloon in a 6, 7, and 8 French guide as a trapping. So we come with a Crusade dual lumen catheter next, and a Gaia 2. And the sequence for parallel wiring is XT, Gaia 2, Confianza 12. Here I try to pass, because I'm quite sure that the XT delineates the vessel course, I will try to get down, which goes rather quickly here. And then I need to make the right turn on the lateral view. So this is the fluoro storage.
We have to come back to slightly medially.
And here it makes this right turn, which looks on the angio okay. Also on the frontal plane next. You see, good, but we have no filling. No filling.
But it was filling before.
Yeah, it was filling before, but the thing is, one of the main sources is via this AVI branch. And now we have covered the AVI branch, and the filling goes down. I'm a little bit, because it's a long pathway, I don't have the feeling on the Gaia here in this position. Yeah? I could be in. Usually when you have passed the occlusion with the Gaia is kind of released.
Yeah, it has to
Yeah?
go
But
smoothly.
here I have 3 centimeter of lesion, which doesn't give me the feeling. So I'm a little bit,
But this is the patent part of the vessel theoretically,
yeah.
because it was filling very well by collaterals.
Yeah, but
So
it
now
was
that you're
filling from the RV branch, you understand? So
Ye-
I've occluded the proximal source of the collateral. And now we only have the filling from retrograde.
Yeah.
And there was a competitive filling, and I'm not quite sure whether I'm in true lumen or not. It feels like,
The way your wire is moving, I think it is in the true lumen.
yeah,
But-
but
You
we
know,
are not
because
yet
your
sure.
every torque turned the wire, I think it is in the true lumen.
So when you are thinking you are in the true lumen, then you do a sliding with the Gaia.
Yeah.
That's the
Yeah, that's what
change
you
of
can, you can see it. If your Gaia tip moves 1:1
Let's
and
see
you move
whether
forward,
we get
because now
some
you should not
impression
have
from left.
resistance.
Left.
Actually,
Left. Really.
but why are you losing?
There is a faint filling.
See, we are losing the filling.
Because there is another lesion distal. Yeah? There is a lesion distal here.
The question is, once you have crossed anterogradely,
Yeah.
it was filling retrogradely, why did it disappear? Why are not seeing the vessel now? Retrograde
Because if you look at the first shot,
it was this
there
lesion
is
there.
some lesion.
But lesion was there
distal.
before also. It
Yeah.
means when it started, lesion was there.
But we
Then
had 2 sources of collateral
RV
supply.
branch and another
RV
thing.
branch.
Absolutely right. So
and
now we have occluded
distal.
RV branch, so that's why it's not filling that
Yeah.
good. But doesn't seem to be lesion there.
Dr. Werner, but when we look back to the initial angiogram, it seems that actually the RCA, I mean distal RCA, is fed by the left.
Yeah, but
Probably-
But let's show the
Can we
first
see
shot.
the original
Yeah, we
angiogram
can-
once
probably
again?
we can,
Let's
Can
go-
we see the original
The first one.
angiogram once again? Yeah.
So we see the first shot,
Can we see it? Yeah, please.
It doesn't seem to be lesion in the distal end.
and
It
there
does
is
not.
No, actually
a
from the distal,
disease.
No, no, no,
There is
just
from
a
the distal
disease
to the
distal.
middle.
Yeah.
Can you show it again?
From the distal to the middle.
You see, the filling is largely by the RV branch and then antegrade from there. The
Yes.
septal filling through the LAD is only till the PD level.
Yeah,
Yes.
actually it is filling PDA, PDA is filling RV branch, RV is filling RC again.
Okay, so that is the situation we are in. So I'm not
So,
quite
so
sure.
you think you have occluded the RV branch?
I
Yes,
have
that is
occluded
why
the
you're not
RV
seeing the
branch.
vessel
So
dystally now.
if your second wire is already where you are, if you pull back the RV branch wire, the other one,
No, no.
maybe
it's
your
occluded by
collateral
the-
flow might be
it's
better because
occluded by the Gaia
We
wire.
can remove the crusade and dilate the proximal RCA.
Yes, that's what I
and
want
that's
to
one
do.
thing. If you feel you are in place,
Because I
you
still have
dilate
the
the-
retrograde option, even if I'm wrong. So we
Yeah.
will remove the XT here. This is the XT wire.
yes, and
Then
Now we
now
can see that, now we can see the
now
vessel
can you
filling.
see it again? Maybe now
Right.
it
No,
might
let me just take out the crusade because it's of no use anymore.
because the other thing that happens is this crusade once it is inside, the lumen is so small and the crusade is so big size that it doesn't let you any of the collateral flows and other flows to. The moment you remove the crusade, I think you will get flow
We'll
if
see
you are in the right place.
if we are at the wrong
But,
right place.
Another
And
thing,
I think you are in the right place.
So take out the trapping balloon.
And let us see the left injection now.
Okay.
but another thing I'm thinking about is that if I mean the integrate device just block the blood flow, integrate blood flow. Actually, the retrograde blood flow
No,
should be
it's
better
still-
than before.
Yeah, but there is a lesion there. There is a diseased area there.
Now see, RV branch is filling less. So it
RV
means RV
branch-
branch is not filling to the bifurcation.
So
at the
I
upper
think
part.
the RV branch got
not
dissected
fixed.
by that
First wire.
the first wire.
That is
So
why
you
it
are
was
not,
filling.
it's
yeah.
not letting you flow back into
No,
the main vessel.
I would disagree. The RV branch is affected because I passed. Yeah, the first wire didn't do anything to the RV branch, but now I have passed the wire through,
Yeah, but
and now the source is good. So
The
we
diagnostic
have
angio,
we have the retrograde option, so there is no failure, even if we are subintimal here. If I try to dilate antegradally, so I need a very good balloon.
1 millimeter?
1 millimeter. What do you have on the shelf?
1 thermo.
the diagnostic angio does not
So-
show any pre-crux lesion.
That should be
The
fine.
RC
1.2
was
into
flowing
6
up to the
thermo.
mid-RCA.
You don't have a 1-0 balloon?
Occlusion starts just after the RB branch. the
Let's
filling
take a
up to
mini
the-
track
yeah.
1-2.
There is no
so
pre-crux
so
lesion,
what's the
diagnostic
plan,
angio.
Dr. Werner? You want to dilate it?
I want to dilate the proximal part as far as I get.
No, but what's your fee? Because I would like to submit that unless I am sure that my distal wire is in the right place, I would
Try
not
to
like to
avoid
dilate.
that. We should
I
not
would
dilate
avoid
it,
dilatation.
yeah.
Yeah, but we will not solve the puzzle because by all angiographic criteria, with the reference image and by the behavior of the wire, it went straight. So both planes, I am
Yeah,
perfectly aligned. So I will dilate. If I am subintimal, this is the first step to reverse cart. I have to dilate anyway.
Okay.
So I'm not giving up any chance of solving the case because
All
the
right.
retrograde option is there all the way.
You're holding the wire now.
And this was parallel wiring with dual lumen catheter, so maybe it saves us the retrograde approach, which, okay, let's see. We have a 1-2 balloon. Let's see how far we get. Where is it coming?
It is safer to dilate proximal with
Please near the
vessel
lesion.
without confirming the
Little bit
wire in the
better,
distal
proximal.
true lumen.
I think we're going across the region now.
I mean, you don't know the wire
Okay,
is in the
start
distal true lumen or not.
2, 3, 4?
Yeah, but this is a general rule, of course.
Yeah.
Yeah?
But
We
If-
are not confirmed whether the wire is in the distal true lumen.
then
Not audible.
I don't lose
not
anything.
audible.
Okay, this is
I
what you are
don't
saying,
lose
that we
anything.
know that once we are not sure about distal lumen
Go
wire,
10, 12.
we should not dilate, but what he is saying
Your
is,
mic is not audible. Okay,
It's not my fault.
I think we need to switch to back to Trivandrum now.
12.
Okay.
Down.
So we were in this.
Yeah, because I saw your
discussion.
wire has already crossed. So
Yeah.
that,
So we did exchange the microcatheter and then did a balloon dilatation with the mini track. I didn't get all the way down, but at least in the proximal part. And while I have released the resistance proximal, I got back the feeling on the Gaia, and the Gaia just slid down. You see here.
Yeah. So that
Yeah.
that's correct. So that was catching it there, but whatever it is, I think if you are in the true lumen,
I
the
am in
wire
the
will.
true lumen.
Yeah, I know you are in the true lumen. Now I'm just making a point here for the audience
Yeah.
that if you are in the true lumen, the wire will just move forward, and you know that you can line it up with your distal angiogram. Here, I think the problem was that the distal angiogram was not being visible, probably because the RB branch was getting occluded by the crusade. I don't know.
So we couldn't follow completely with the balloon. So I did go as far as possible. Then we dilated the proximal part with a 2O balloon. And there is still some point where it's not fully expanded. We will have to go with a non-compliant. But subsequently, the rearray 10 could then pass. You see it there. So it's clearly beyond the distal cap. And now we dilate and go back with a 2O. And then, yeah, it would be great for such a young person here probably to optimize the stenting with IVUS. OCT. Then someone needs to tell me how to do it. You
Yeah.
want OCT?
You want to do it with OCT? Yeah, I think OCT should be
So
there.
let me just make the point that this is a very quick procedure. We have just wasted maybe 18 minutes of fluoro time with parallel wiring. Yeah?
We need 2 meter balloon now.
And
Okay,
nobody did it
Dr.
during the whole procedure.
Dr. Werner, you can, we need to switch. I think Dr. Pratap has
But
crossed.
these were not 10 minutes. You know.
No, we'll come back to you. You see,
I know
I am
the
making
allotment
things,
time.
you see, now that I am on the chair, I'm making things very more comfortable.
I fully agree.
Every 5
Yeah.
minutes you are back.
I fully
So that
agree.
you are
Okay.
there all 45. This is what I had thought and planned, you know.
Okay.
But somehow, you know, you plan something, it doesn't work out.
So,
So,
I'm up to
Because
you.
Dr. Pratap has crossed.
Okay.
Let me go back there.
Yes, of course.
Because Dr. Werner, can you hear us?
Yes.
So we want to come back to you to see your OCT. Can you explain what you're doing now? I think.
No, I cannot explain.
So the case is over for you.
No, we are yet to do a lot.
So we did.
Whatever,
let's
you
show
can show
some
the
of
last picture and then we will go back to
image.
Trivandrum.
3.
Yeah.
Yeah, or let's go to the. Rupali doesn't have a mic. So,
Let us go.
so this we did 2 runs actually, and we show you the angio right away. So this is the distal end, about 1-2 centimeters proximal to the crux
Okay.
that you see right now, the cross section.
Yes.
And
so the vessel size.
it is told to me that this would be a concentric, the outer diameter 2.9 with a fibrotic concentric plug. And now
Correct.
we go back where we dilated with a
So there's
2.5
some-
non-compliant.
Mhm.
This is the second run? Or
First run.
the first run. So the run from the proximal through the CTO.
Hmm.
Yeah, so this is about the level of the RV branch. Maybe that was,
So that flap was at the level of the RV branch, where you.
Dissected once with the
Yeah.
first wire. Yeah.
this is all dissection, but we are true lumen. Yeah? We are
Yes.
true lumen all the way. which I also confirmed by Angio, because I did a retrograde shot. When you are not sure whether you are allowed to do antegrade injection, you give a retrograde shot. The retrograde filling is completely gone. Collaterals don't work anymore, so you have full antegrade filling. And this is...
Yeah, so I think this wire went
All through two
intraluminal all
Yeah.
through.
Yes.
Yeah, that's what
It
people
was
should
only the-
understand is it's not subintimal technique to use a parallel wire. We are staying in the plaque, but the first wire simply doesn't penetrate the distal cap. So I take a second wire with more power, and then I penetrate the proximal cap from inside the plaque.
Yeah, but if the first wire exits subintimally towards the RV branch, still this picture would look the same. Only if it is on the RV branch side, it got subintimal, and
So-
you continued
you want-
intimal
So we
parallel
have
wiring.
dilated, and we'll make a shot. Do we have biplane and go back to angio? We have
Yeah.
given some nitro. Show the, please, the two angios on the, yes.
You want some nitro now?
No, no,
Okay.
no. So we do some shots. Okay. Looks already quite nice.
Yeah.
So we start according to the IVUS, the OCT. You see the distal dissection, which we also see. Distal to the dissection with a 2.538, and then see how long the proximal 3.0. What
True.
is the proximal reference diameter?
3.5 is diameter.
3.5.
So we can take 3 when we,
Yeah.
Yeah.
And then we post dilate.
and distal we can give a leverage of 2.75.
Yeah.
Maybe
So we'll take 2.75 distally?
No, we want to start
2.5.
with 2.5, low,
think-
slow,
And then we can
and
dilate
then
it.
go post
True.
dilation.
2.538.
well,
Yes.
this dissection could be because of the balloon also, I don't know.
Yes, ballooning. It's
I
clear
think this
balloon
is
dissection.
because of the balloon, because
Yeah.
the wire didn't dissect here.
You see, still the RV branch is there.
Yeah.
Shall I protect the RV branch?
You see,
Maybe.
my feeling is whatever was
Come
happening,
on.
you were in the lumen,
I take out the retrograde
but
system
the
at this
crusade
point.
which was sitting there did not let flows link from the RV branch back into the main vessel.
Let
that
me,
is the reason.
Let me secure this RV branch, because this case is
Just hold on,
anyway
he wants
much too quick. So let's do secure. The RV branch is not small. Maybe I dilate the
Wait,
ostium.
wait. I'll
Give
just
me a
give you-
talker. No, introducer. What do you think? RV branch are useless?
Actually,
Oh, well-
do you think another strategy could be reasonable because we have a good collateral
you can
from
take
the
it.
left to RV branch? Also,
Yeah.
even though we compromise the blood flow to, integrate blood flow to RV branch, it should be okay.
Yeah, yeah.
I don't know.
I
Yeah,
agree.
that's okay. No, because I am not. Only thing is anatomically, if the
And then
branch
we can
looks
make our
big,
procedure more simple.
anatomically, if the branch looks big, then you might like to do a balloon dilatation if you have
With a 2.0 balloon.
yeah.
Let's see.
But I won't chase it because
Yeah, of
the
course.
myocardial supply of RV branch is like whenever you look for supply to the myocardium, RV branch is not accounted for unless it is extending onto the PLV.
And well, I actually feel the RV branch need not be protected in this patient.
Yeah.
It's not a good
So
myo,
we have
not a large
this
myocardium.
wire is completely gone. Okay. So we have changed actually the recanalization wire to a Sion wire.
Sometimes you actually
So
make
I
procedure
think
complex actually and required.
you can just complete the case. We have some 7 minutes left, and we can go back to Trivandrum and
Yeah.
because I think there also some final results might be available.
Okay.
Okay. All right. So thank you, Dr. Werner. I think it was a very nice presentation.
At least we have one parallel case.
Yeah. So